I'm going to give a quick overview of where we are and how we got here, and I think that we've obviously got a lot to learn as in any other field of sports or dance medicine. So our clinic was founded in 1974. As far as we know, it was the first clinic for kids, sports kids or dance kids in the country, maybe the world. But at that point, we had one doctor, one secretary, and saw just about 100 patients the first year. In 1975, some of the dancers have been coming to us individually because we were stressing return to function. So if a dancer sprained their ankle, we did not put them in a cast, which was the standard of care at that time. With a sprained ankle, we would put in a cast for 6 weeks. Okay, and so we did not have that approach, and we tried to get them back in a safe and effective fashion to dance. And so the dancers started coming in individually. Stephanie Moy came in to see us during that first year. Elaine Bauer, they both happened to be union reps for the Boston Ballet. So next year we started an agreement with the Boston Ballet and started to systematically cover them. Initially myself and Arlene. Is Arlene here? No.
She's not here now.
Okay. And then our physical therapy department under leadership of Mickey Casella got involved progressively. We started covering the ballet school in 1980, and then Mickey was instrumental in founding the Adaptive Dance Program 202. You might get a chance to talk to her. She's very shy, but if you get her out of her shell, she might open up a little bit. So our thrust here is really, and my main emphasis on this part of the talk will be on preventing dance injuries, and this is where we're in a learning process. The more you learn about the demands of a particular dance mode, the better opportunity you have to step in and make good suggestions for prevention or training or both perhaps. So this is one of our early studies. It's considered a landmark study. We looked at the physiologic profiles of our professional dancers with the assumption that maybe is the goal that the younger dancers is striving to attain. So here's Elaine Bauer being tested over at the Northeastern University Exercise Physiology Department labs. And we looked at a variety of different dance techniques using EMG and nerve conduction studies and so forth, and started to get an idea of what were the demands on the body, on the muscles in particular, the joints, and of course always bear in mind that it's more than just the science of movement, but actually the dancer is performing an artistic endeavor. The dancer unique problems, unique injuries? The answer is yes and yes. I think as many of you know. They get special injuries, and we'll get a kid in who's quote-unquote sprained her ankle. She's sent to us by another doctor. She sprained her ankle and hasn't sprained her ankle. Actually, there's no history. Nothing in history suggests that. What she actually has is an os trigonum in the back of her ankle causing pain. And here's one of the dancers has this type of demand, and we'll talk about Mark in a few moments. He was one of our very powerful dancers in the Boston Ballet. And of course, they put demands all over the body. They put demands on the back as well as the lower extremity. Our focus today is going to be on the lower extremity, particularly the foot and ankle. But injuries do occur, and our question is how do we work backwards from the injury and figure out why it occurred and what we can maybe do to prevent it. So we started at the basics of the musculoskeletal system, the spine. Most of our issues in dancers are either starting from the spine down, lower extremity. We have had have other types of injuries. I'll use the spine as an example. If you put a weight on the spine, you can bend it with 4 pounds deformity, but obviously it has ability to have tremendously much more strength and sustain much more loads when the use of the muscles and activities are involved. And the dancers do funny things with their bodies. This is certainly one of them. You notice the tape on this young lady's foot, and she'd had sustained a fracture of her first toe, and we built her a special little brace to put over the toe. And so here's what happens when you line the foot up in a way that they aren't usually used by most human beings. Of course, muscle tendon units, if you injure a muscle tendon unit, it's a strain. And here's an example of a sprain of the ankle, where the swelling is spread all down the foot. And I'm sure you'll hear from many of the speakers today about how important and difficult sometimes managing sprained ankles in dancers is, because sometimes you don't have enough time to really fully recover and rehabilitate. Tendinitis can occur in the dancer. And this is an MRI of a stress fracture of the tibia. Just to remind all of us as far as our vocabulary, we think in terms of a mechanism of injury. Acute macrotrauma, someone twists their ankle, has one episode of force. Repetitive microtrauma is doing something repetitively, repetitive plie, repetitive releve, and so forth, which can also injure tissue if you do it over perhaps too short a period of time and long enough time. So these combination of these repetitive microtrauma movements, plus perhaps certain anatomic and physiological predispositions, that results in these stress injuries, stress syndromes, and include stress fracture. So here's a lateral view of the dancer that you just saw the slide of recently. And you see the stress fracture, the black line stress fracture in front of his tibia. And you see he's got an addition to his anatomy now. Because on stage, he came down from a jump and snap. So we got to take even the overuse injuries, the so-called stress injuries, very seriously, particularly in the dancer. So the risk factors, why does a dancer come in with an injury? There's probably a combination of 2, 3, or even 4 of these various risk factors that results in this kid being injured. Training technique, muscle imbalance, and so forth. This is the individual factors. And then, of course, the environmental factors that can help work. And I'll go through each of these sequentially and to give us a perspective on what you're going to be looking for, either one of your own students or one of your own patients and so forth. Training is someone telling you what to do, how much to do it, and over what short a period of time. The overuse syndromes often are associated with maltraining. The type of training, the amount of training, and the rate of progression of training are factors that we look for and we try to tease out when we have a kid come in with an injury. And we now know that in most cases, it's probably safe if you work up to it progressively to a maximum of maybe 20 hours a week. And as most of you know who take care of, say, dancers and gymnasts, sometimes the gymnasts get beyond that. But in general, a kid can safely do this. This is data that came from the East German, the Leipzig Center for Sports Training. They've had a tremendous value and it's tremendously good at keeping data. And science is measurement, right? If you have a clinical impression, you look at someone and say, oh, you should do a little bit of this, a little bit of that, a little bit of this, you're maybe more of a guru. But if you actually measure it, then you're approaching the scientific method. The 10% rule is a tried and true rule for us. Basically, in general, you should increase the volume or intensity of training more than 10% a week. So using a running example, the kid's running 20 minutes 3 times a week. They probably safely run 22 minutes 3 times a week the next week. And so here's a little girl from Kansas City, and she's taking 10, 12 hours of training a week. In other words, she's a very serious dance student. And then she comes to the Boston Ballet Summer School, and she's now taking 6 hours a day, and that's a tremendous bump up in volume of training. And we see the kids come in, it's usually about the second week of the summer programs, come in and start coming in with the various overuse injuries, because that one principle has been violated, a rate of progression of training. And again, as I said, we've done a lot of work looking at how the body responds. Here's Elaine Bauer again with her EMG probes on, helping us to learn what muscles are used in the dancers. Technique is a very touchy subject, basically. How someone dances, what schools of dance they're using, what is proper or improper. And this is where we come in to interact with the artistic end of dance. Some dancers do have a perfect body for dance, very few, okay? But the ideal is sought after. This is one of our very good dancers in Boston Ballet a few years back. And unfortunately, some kids are like this. This kid, for instance, most likely doesn't have anatomically the ability to turn out at her hips. And so as you see, she's forcing to turn out below the knees. And then as a result, there's putting asymmetric pressure on her patella. And that is a formula for disaster. And again, result of an old injury, perhaps, or anatomic alignment, or problems at the ankle, and perhaps the inverted muscles are stronger than the everted muscles. The everted muscles, after an old sprain, have not been properly rehabilitated. And so you get a dancer who starts to sickle. Now, there is a culprit in this whole thing. It's the other teacher. Okay. And I was first taught this by E. Virginia. She was quite a character, but she would, Dr. Micheli, this young lady could have been a wonderful dancer, but other teacher ruined them. So that's where the artistic interaction occurs sometimes and so forth. And so here's the other teacher. He's so in shape and he didn't want to show his face. But I think there is this element, and then on how the kids have been progressed. And there obviously there's some truth in this. Basically, some kids are given too much training too early. You'll hear about what we think are the criteria for progressing on to point in ballet, for instance. But there's certainly something to that. By the way, that was from North Carolina School of the Arts, and I went down there, and that other teacher was showing me around. He said, that boy over there is going to be a very good dancer, but he's in his growth spurt now, so we're backing off on his training. They knew that. Yeah. They knew that risk factor, and we were just beginning to get a sense of that. We knew that risk factor in sports injuries, but they recognized it in dance injuries. Muscle tendon imbalance, we all think that dancers are very, very flexible, and certainly if you are constitutionally a little more flexible, you have a bit easier time getting used to the dance demands. You may have some problem with power if you're more flexible, but dancers are known for their flexibility. This is one of our studies, looking at with a latent flexometer, looking at the range of motion here, but bear in mind that if a kid only does dance, you may have the loosest hamstrings in the world and the tightest ITBs, yes. Tighter than any football player, okay? If it only does ballet dance. And so getting this kid so that she progresses onward, she was a very strong little devil, but she had muscle imbalances all over the lower extremities, and fortunately she came to with a minor injury and we were able to address it. This is from one of our studies. We're using Cybex strength testing at that time. It was very, very common. And you see the quad to ham ratio is relatively normal for these dancers, probably similar to what you see in a soccer player. In fact, we now know that if the hamstring to quad ratio is less than 0.6, that's a risk factor for ACL injuries, for instance, in any sport or activity. But look at the relative dorsiflexion, plantar flexion strength in these group of dancers. These were professional women dancers, females, and you see the rather dramatic imbalance. So dance, if you only do it, does induce muscle imbalances. You may also have muscle imbalances from growth. You may also have muscle imbalances from your own constitutional makeup. Anatomic alignment is sort of a very important principle in dance, much more so than in many of the other activities we deal with, such as sports activities and so forth. In fact, a soccer player can be a bit ding-toed, and they claim it's sometimes an advantage as far as certain types of kicks and so forth, but not so the dancer. The dancer, if they have too much of an anatomic malalignment, are going to have trouble dancing. This is a kid that has what we call miserable malalignment. She has too much femoral anteversion. Her hips are pointed too much in, so she doesn't have natural turnout at the hips. She has genu valgum tibia vera, and she has a functional pronation. Some of these kids, when they were 5 or 6, are in-toeing, sort of, the doctor said, pediatrician says, aha, I've got just the activity for her, ballet, because they teach turnout, okay? So now at the age of 15 or 16, this kid's starting to have significant increased patellofemoral pain or whatever, or different overuse injuries. She loves ballet, wants to be a professional dancer, and she really doesn't have the body for it. And I was in Australia one time giving some lectures, and they presented a young male dancer to me, and he just didn't have the body for the demands of ballet, and he was very hopefully to become a dancer and so forth. And so I was trying to figure out how before this audience I was going to say, well, I don't think he's going to make us a dancer, politely, but it can be touchy sometimes. And of course, the Q angle is one of the measurements that we look at in a patellofemoral mechanism situation, as an example of what we do. So this depicts the fact that if you have some anatomic malalignments at the hip and the lower leg, you may pay the price at the knee in this instance. There are anatomic constraints in every dancer, basically. Is that how much they can turn out or how much they can releve, how much turnout they have on one hip versus the other, and so forth. And I think that the teacher has to be cognizant enough to look for this. I mean, the kids standing there and the kids standing here may have different anatomic constraints which limit how far they can go in certain instances, or maybe how quickly they can go. And all dancers know this. They have a little bit more plantar flexion on one side than the other, and so forth. That's just their body habitus. Same thing with dorsiflexion. And of course, it's often the male dancers start getting anterior impingement in the dance group, particularly as they get a bit older. And of course, but here is a nice alignment. You'll hear about this in some of our subsequent talks. And we literally do this. If a kid comes in and they're having problems around the ankle, for instance, we'll get usually a demi-point, unless they brought their point shoes in. We'll usually get a demi-point lateral, and we want to see a line go right through the tibia, right through the first metatarsal. And if it doesn't, if they're a little bit more dorsiflex than that, they usually have some element of posterior impingement going on. We'll talk a little bit about that one. Footwear in dance, it's sort of, you'll hear about that in detail once again. It wasn't designed to basically protect the foot, of course. and the male dancers have even less support in some ways. Here's the Freed factory in London, which I visited, and saw how they make these shoes, and you see the various custom shoes for dancers all over the world. And you all know what a dancer does when they first get their point shoe. They bang it on the steps, bang, 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 bend it around and put it on, and away they go. So as opposed to certain other activities, such as, say, distance running, where there's a pretty good progression in our understanding of footwear and protective footwear and so forth, dance is still sort of in that mode. Surface is very important. The hardness of surface, we're recognizing that more and more. When we used to, Boston Ballet used to tour a fair amount. Our ballet danced at the Los Angeles, some kind of a big theater there, I forget which it was, but anyway, so the floor was hard on a rock. They had sprung, they had elevators in the ceiling and so forth. We got 3 stress fractures in that 1 4-day stand there. So the surface is important. And the Boston Ballet too, which tours around New England and so forth, is dancing on a great variety of different surfaces. And often the hardness is just going to be a factor, one of the factors perhaps, in them getting a stress fracture, say, or an overuse injury. Associated illness or injury, we sometimes don't think about this, but for instance, in a professional company, and during Nutcracker, for instance, if one of the dancers gets a viral illness, it'll sweep through the company. And there's very, very good studies that have shown that if you have a viral illness, you have an increased risk of musculoskeletal injury. It just really increases your chance of getting injury. This was taken in London when we were touring with this nice man, Rudolph Nureyev. Very pleasant guy. He used to cuss out the dancers, unbelievable. Nutrition is a risk factor. We're all aware of that. The dancers are doing tremendously demanding things with their bodies, and yet they have to stay aesthetically slim and so forth. So there's a constant battle, and we're fortunate to have a nutritionist, Jan Hangen, with us, who works with the ballet, for instance, and with young dancers, who's pretty good at helping them balance the metabolic demands of their art with the nutritional intake. Cultural deconditioning, I think, is very pertinent in this country. Increasingly, the kids in general are getting less general physical activity, okay? And so you suddenly put them into a regimen like this, and you can get injuries. We went through a period of time when we had a lot of Russian teachers in Boston Ballet. And they were used to kids who, in order to save on the subway, they would walk the 7 miles to their dance studio from home. And they were really in shape and tough. They had stronger tissues. And we know that. There have been a lot of studies that look at the response of the body, the bones, the ligaments, muscle tendon units to progressive resistive training. And I think that we have to be aware of that when we're dealing with the suburban kid who wants to play with the kid next door, so their father puts him in the car and drives her across the street and so forth. And so this little American kid is going to have some supplemental training in some cases. And we do believe in strength training for kids. And you'll hear more about that. Emily will talk about the training regimens that we recommend for the dancers. And you'll hear about strength training from some of my colleagues and so forth. But I think that they can't just naturally assume that kids have strong bodies anymore. And I certainly have talked about my grandmother in the past, about this, My grandmother grew up in Spain. She used to work physically probably from the age of this, When I was a kid, I remember we used to go along the tracks and pick up spare coal, and she'd put it in her half wash cut. She was in her 60s, right? She'd get a hand towel, spin it, put it on top of her head, then down, get the wash tub of coal, put it on her head, walk home with a kid in each hand. I don't think she'd have got injured, for instance, if she played soccer or something like that. She wasn't perfect. She used to smoke a cigar while doing it. Very impressive. Smoking no-handed. Incredible. Psychological stress. This is something that we sometimes don't talk about much, but Bill Hamilton's wife was a former core dancer in New York City Ballet, and she's a psychologist that addressed this a lot. But here's a bunch of kids who were working together, living very close to each other for 60, 70 hours a week, and then they're competing at the same time for roles. And there's a sort of a interesting dynamic in the professional dance company, or even in school dance companies such as the conservatory or high school programs and so forth. And finally, growth we've mentioned. The growth spurt is often the culprit for many musculoskeletal injuries. This is the rate of growth. The babies are growing pretty rapidly initially. Every kid has a different growth growth chart, of course. One kid might be here, one here, and so forth. But during that time, when there's rapid growth in the physes, in the growth plates, this musculoskeletal, the extensor mechanism, for instance, is put under relative stress. There's a tendency for it to be pulled toward the outside by the iliotibial band, 1/3 of whose fibers go up to it. And as a result, growth can be a risk factor. So we asked that. Kid comes in with this or that type of overuse injury, and she's in a company or in a school. And what's her growth been like recently? And it's important. So overview is that ideally you assess the kid, you would adapt their training to that particular child and their body, and you have to bear in mind always, of course, the dance technique that they're being asked to do for a given performance or show, and with an eye toward injury prevention also, are always extremely important for everybody. So we have to look at the risk factors of an individual dancer, and the kid comes in, we get a history and so forth, we do physical examination, get an idea of what their risks might be, look at the dance-specific risk factors for them, whether it's Irish step, ballet, contemporary, and then, of course, ideally introduce corrective conditioning and training for the kid, and hopefully we can prevent this cavalcade. So the theme today is the foot and ankle injuries. I'm just going to give you a little bit of a sense of overview. This is an article we published a few years ago, and as you'll see, the foot and ankle injuries were the predominant area of injury of all the dance injuries we saw in our clinic at that time. Dr. Luke was one of our fellows at that time, did an overview survey. And so one of the real culprits is the one I mentioned earlier, the os trigonum, and I'll show you what that is basically. Now, I'm sure Bridget's going to give you some cases, examples of this, but this is a relatively quote-unquote normal talus. This is the lateral process and medial process, and you can get a stress fracture of this little devil by repetitive plantar flexion because it gets caught in the back of the ankle like a nutcracker, pardon the expression. And we know now that there's a much higher incidence of os trigonum fractures, free pieces here, in dancers there is in the general public. That's an ongoing study we actually have in our center here, looking at the dancers and seeing what their incidence is. We think that when they get to the professional ballet level, for instance, the incidence is over 50%, whereas in the general population it's supposedly 8%. We think it's an acquired lesion, such acquired from repetitive dance. Here's an example of one. I'm sure you'll see more in the future, but this thing just starts to get cut, and sometimes we can get a kid through a season. Dr. Demicourt will talk about ultrasound. He can go on ultrasound, do an ultrasound injection. Dr. Stracolini, again, can do the same thing in basic. We try to get them through the season, but by and large, once this starts to become symptomatic, if they want to continue dancing, we generally have to go in and remove it, and the associated scar tissue around it. That's called the os trigonum, or posterior impingement of the ankle. Just an idea of the extent of this problem is that this goes back to 1990, and in recent years, and this is this year through May, I'm doing 25 or 30 of these a year on these kids, and that compared to some of the other things we see in the young athletic population, that's a pretty large amount of posterior impingement for a condition that most physicians don't know about. The average orthopedist is barely aware of os trigonum syndrome, and this shows you the extent of that we're seeing in our programs here. So it's a ongoing issue. I wish we could figure out a way to prevent the os trigonum, for instance, but it's probably related to amount of training. But we're going to try to keep studying this problem and get some answers, hopefully. Thank you very much.